And we're back with Marc Surdyka. Marc, thanks for coming back on. You were on 10 episodes ago for episode 200. How are you doing?
I'm doing well. Thanks for having me back.
Yeah, I'm stoked for having you back on. This time it's going to be on the topic of low back pain rehab. A month or two ago, E3 came out with a YouTube video and an article that you and Tony made on lower back pain. So, this topic and the general flow of this conversation is going to be largely based on those pieces. So, I'm going to link them in the show notes. I strongly recommend watching the video and or reading the article. I thought it was great. So, kind of the outline or the flow today will be on the general topic of lower back pain. But if someone wants kind of a more concise, truncated version of our conversation today, would recommend going to the YouTube video and the article. We'll just dive right into it. So, this is kind of a big question to start out, Marc, but what actually is low back pain?
Yeah, and as I always do, I'm going to give some disclaimers in terms of I'm not going to provide research for every statement that I make. We have individual blogs about a lot of these topics with research cited, and you recently created a resource guide that I don't know when this episode is going to go out, but that resource guide, if you sign up for our newsletter or you're already a member of our newsletter, will have papers that Chris recommends reading for acute low back pain. So there's resources there. And then I'll do my best to be nuanced as always, but what we can fit in a 1 hour podcast might not fully represent the discussions I have with patients, colleagues, and mentees, or fully represent my individual beliefs and understanding. And we have a lot of great individual episodes about different diagnoses. Like you just did one about spondies. You've done one spinal stenosis with Jim Eubanks. Tom Jessen has been on twice, and I'm sure there's others. So we have a lot of great individual episodes and blogs and YouTube videos about that. So first question, what is low back pain? First, we have to identify the low back. So I'm going to use this very precise description from the 4th edition of Clinical Anatomy of the Lumbar Spine and Sacrum from Nikolai Bogduk. Lumbar spinal pain is defined as pain perceived within a region bounded laterally by the lateral borders of the erector spinae, superiorly by an imaginary transverse line through the T12 spinous process, and inferiorly by a line through the S1 spinous process. So that's a fancy way of saying the lumbar spine area. Then he goes on to say that sacral pain is defined as pain perceived within a region overlying the sacrum, bounded laterally by imaginary vertical lines through the posterior superior and posterior inferior iliac spines, superiorly by a transverse line through the S1 spinous process, and inferiorly by a transverse line through the posterior sacrococcygeal joints, simplified as the sacroiliac region. So then he goes on to say low back pain can then be defined as pain perceived as arising from either of these two areas or from a combination of both. Whether or not the pain radiates elsewhere is another matter. The cardinal feature is that it appears to arise in these areas. This definition does not presuppose the cause of pain, nor does it imply that the source of pain actually lies in the lumbar spine or sacrum. It is simply a definition based essentially on where a patient points to when they indicate where they feel their pain is stemming from. So that answers that question kind of in a complex manner. What is low back pain? But the low back, or when we're thinking about low back pain, it's really lumbar spine region, sacroiliac joint region.
And then from there, when people say they have low back pain or when low back pain is discussed, there's so many potential different types of reasons why an individual has low back pain. Can you touch on or kind of differentiate some of these big differentials or diagnoses that people may be familiar with or have heard of?
Yeah, and I'm going to try to be kind of nuanced with this answer as well. So it depends on how we're classifying or categorizing it. If we're basing it on time, you might hear acute low back pain versus chronic or persistent low back pain. And chronic or persistent low back pain is often described as pain that's been present for 3 or more months, although there isn't a strict cutoff. This definition might be used for research purposes or ease of discussion, right? So there's that time component that might be used as it relates to low back pain. In PT school, students might learn about the clinical practice guidelines linked to the International Classification of Functioning, Disability, and Health from the orthopedic section of the American Physical Therapy Association, which kind of describes patients by their presentation. So an example would be acute or subacute low back pain with mobility deficits, right? Another example is acute, subacute, or chronic low back pain with movement coordination impairments. And admittedly, these aren't my favorites, but I understand that trying to create a framework for management can be helpful for some individuals. For me, realistically, I am taking into consideration the time component, but I'm thinking about specific pathoanatomical diagnoses, examples being spinal stenosis, spondylolisthesis, disc herniations, fractures, etc. And I assume we'll touch on the topic of non-specific low back pain. But before going into that, if we go back to thinking about what is low back pain, we could try to make a connection between these pathoanatomical diagnoses and different types of pain. So this is also best described by Nikolai Bogduk in his 2009 paper titled On the Definitions and Physiology of Back Pain, Referred Pain, and Radicular Pain. So the first is nociceptive back pain. And this would be a structure in the low back gets irritated, the facet, the intervertebral disc, the SI joint, and pain is generally present in that region. So that's that nociceptive back pain. Then there's somatic referred pain, usually just referred to as referred pain. This would be a structure in the low back gets irritated. Let's say the intervertebral disc again. But this time, in addition to that localized low back pain, there's pain down the back of the thigh above the knee. So an irritated structure in the low back is referring pain elsewhere, and this is not nerve related. And this is like a type of pain that whether you're a clinician or patient, you might hear about this treatment rationale of centralization or peripheralization of trying to centralize, those symptoms, meaning trying to create those symptoms more in the low back and kind of pulling them out of the leg with something like, a repeated movement. But that's referred pain. Then there's radicular pain. So now let's say a disc herniation that contributes to compression and inflammation of a nerve leads to pain down the leg. So that is nerve related, the radicular pain. And then there's radiculopathy, which Bogduk describes as a neurological state in which conduction is blocked along a spinal nerve or its roots. So this is numbness, weakness, diminished reflexes, objective neurological signs. And you can have radicular pain, so that kind of nerve pain, without radiculopathy. And you can have radiculopathy without that nerve pain, but they often coexist. So they often coexist, but they are separate entities.
Yeah, I appreciate you outlining all that, and it can still be confusing, but that Bogduk paper, I'll link it as well because I think it is a great continued resource to look back and return to those kind of different diagnoses. So you mentioned the time component. You mentioned different kind of movement impairment or type of classification components that you're not a huge fan of, and then there's kind of this pathoanatomical component. What else, if anything, do you want to touch on just the different or common types before we move on?
I think it probably is important to touch on what people mean when they say non-specific low back pain, or at least what that means to me. And I know that, you kind of wrote that in the resource guide, which is nice. So just for people listening, whether you're a clinician or not, non-specific low back pain doesn't mean that there isn't a structure that is irritated. It doesn't mean that treatment is non-specific. Really, what it's referring to is that the structure that's irritated might be difficult to identify because of the validity and reliability of our test to identify an irritated structure. And even if we could reliably identify that irritated structure, it doesn't necessarily change management. And what I mean by that is that it doesn't necessarily change management from a physical therapy perspective. There are going to be some diagnoses, and these are what people refer to as the more specific diagnoses, things like infections, cancer, even cases of disc herniations with lumbar radiculopathy, etc., that might require specific medical management. So if somebody has lumbar radiculopathy and they have radicular pain, they might benefit from imaging and they might benefit from surgery. And maybe their pain is so severe that they would even benefit from an injection, right? But let's say under this category of the non-specific low back pain, even if you are, even if your consideration is that, let's say it's disc related, like, hey, it's localized low back pain, and there's also some referred pain down the back of the thigh, above the knee. The management doesn't necessarily, and we're going to get into this, but the management doesn't necessarily change significantly from the perspective of a physical therapist, because you're still treating the person in front of you based on their presentation, based on their aggravating factors, based on their alleviating factors. And you might say, well, hey, if they have these symptoms, I know that repetitive extension of the low back can centralize those symptoms and improve it. But we don't have these treatment-based algorithms that are so often described confidently. And so you're always going to base your treatment on the person regardless, unless, once again, they do need imaging. They do need a more specific medical management. I don't know if that was a very concise way of saying that, but
yeah, well, this is challenging because we are trying to touch on a lot of different types of low back pain and provide some context for each specific scenario. I think that was a good summary of a hard thing to simplify for non-specific low back pain. And later on in this conversation, we'll discuss what can we do for low back pain, and a lot of these things that Marc's mentioning in a lot of the different diagnoses, it will be similar strategies or thought processes, but it is person dependent, and some of the diagnosis plays a role, but a lot of it is how they're presenting, what they're limited by, and what they want to get back to. In the YouTube video and in the article, you also had this section of you are more than your diagnosis. Can you touch on what that means and what you talked about?
Again, that kind of just ties in with what I just said. And I'm just going to read one or two sentences that I wrote in there. So I said, the common belief is that a diagnosis completely dictates the rehabilitation process. In reality, a diagnosis can guide rehabilitation, but the history and presentation of the person are often more important. Two people can technically have the same diagnosis, but they might have vastly different symptoms, aggravating factors, alleviating factors, functional capabilities, goals, lifestyles, etc. And I give some examples of that in the video, in the blog. But another example that's kind of relevant, because you just talked about spondies and spondylolisthesis recently on a podcast episode, is that years ago I made a YouTube video about spondylolisthesis, and I provide the option to do low back extension strengthening exercises at some point in your rehab for a spondylolisthesis. And a lot of the comments in that YouTube video are, you're a bad physical therapist, that's dangerous, that's harmful, you shouldn't do extension-based exercises for spondylolisthesis. And the problem with that is that we are basing our rationale simply on the diagnosis rather than the presentation or the context in which that diagnosis exists. So maybe someone who's 75 years old, 80 years old, symptomatic spondylolisthesis, that extension is aggravating, worsening their symptoms. Maybe that is something that you don't do in that moment. That's fine. And maybe that's a temporary modification. Same thing. Maybe you have a young gymnast and they have a spondylolisthesis. They recently had a fracture, and it's kind of contraindicated to be loading into extension to some degree. That's fine. But then if you take into consideration, well, this gymnast needs to get back to back extensions, backward bending, doing all of these movements, eventually you're going to have to load them into extension, and you're going to have to do some low back extension strengthening. So that's where, the diagnosis might matter, but it doesn't necessarily fully dictate the rehabilitation process. The same thing goes into what I just talked about with like the disc or even disc herniations. If you were to poll the average person, and I'm not talking about our listeners, but maybe people who don't follow rehab, don't listen to podcasts, and you ask, hey, if you were to have a disc injury or a disc herniation, what movement should you 100% avoid? I would imagine a lot of them at some point might have heard, well, you need to avoid bending forward. You need to avoid lumbar flexion. And, they probably wouldn't use lumbar flexion, but in many cases that might be good advice. That might be, appropriate for a temporary amount of time. But there are going to be some times, and for some individuals, where maybe that's an alleviating factor, right? Or just not a problematic factor. So that's the idea that you're more than a diagnosis, and the diagnosis alone isn't going to tell you exactly what you can or cannot do. And the reason that matters is that a diagnosis can make people become fearful of movements, exercises, activities, just based on those beliefs, rather than based on, how they're actually presenting.
And that explanation may be a similar explanation to that next topic that you discussed in the video of you're more than your X-ray and MRI. Is that a similar theme?
Yeah, because there are so many imaging studies that show that a lot of these findings on imaging are common in asymptomatic individuals, whether it's a disc degeneration, disc bulge, spinal stenosis, spondylolisthesis, disc herniations. Like all of these things are present in individuals who are asymptomatic. Not everyone's going to have that, but we see those in asymptomatic individuals. We also see that the degree of change on imaging doesn't necessarily correlate with the person's symptoms or function, right? So you could have a bigger disc herniation than somebody else, and you both have symptoms, but the person with the bigger disc herniation might have less symptoms. They might recover faster. The imaging doesn't necessarily have to change. So you have this, disc degeneration or disc bulge on imaging. You have symptoms. Your symptoms go away. You're back to fully functioning. Guess what? That disc bulge or that disc degeneration might still be present on that image. And for that reason, x-rays and MRIs aren't recommended for most instances of low back pain. Once again, this is not to say that it's never recommended. There are cases. Someone has, radiculopathy, severe motor weakness, bowel bladder changes. Maybe there's suspicion of a fracture, suspicion of cancer, right? Those kinds of things, yeah, x-rays and MRIs might be warranted. But for these other things that surgery isn't a consideration, then, most likely imaging is not going to be recommended. And oftentimes imaging, right, in the long term, is going to cost more money. It can create unnecessary worry, and it may lead to worse outcomes because it leads to further medical tests or treatments that are so, yeah, it does tie in to, hey, just because you have a certain finding on imaging, doesn't necessarily mean that tells the whole story and that it's going to dictate what you can or can't do throughout your rehab and, beyond. And we hear this as physical therapists. We'll see somebody who had back pain 20 years ago and they go, yeah, I've had a disc herniation from my 20s that's just been problematic since then. And sure, it's possible that that is part of their problem, but it's also possible that they were just led to believe that that was their primary problem, and maybe there were other contributing factors that were more so in their control than something that showed up on an image.
The next section is this big topic of low back pain and posture. A lot of narratives around people have low back pain because the postures that they were in that led them to having back pain, or they need to change their posture now that they have back symptoms. Can you elaborate on what is the correlation, if any, between low back pain and certain postures, and maybe times when we may want to adjust positions or postures in the context of low back pain?
Yeah, and the way that you and I are going to have this discussion, or the way that we would have this discussion with other physical therapists or other clinicians, is going to differ than how we would discuss it with the patient. If a patient comes in and says, I have low back pain, it's because of my anterior pelvic tilt, it's because of my posture, I'm not going to automatically dismiss that. I'm going to try to learn more. Tell me more about that. Tell me why you think that, and just get a better understanding of their beliefs, and why they have those beliefs. And then that gives me a better framework for having this discussion with them. Now, in terms of, is low back pain caused by poor posture, right? If we look at the totality of the research, that correlation is going to be non-existent or poor. And we can find some research that says, oh, well, these individuals, maybe have low back pain with these postures, but from the totality of the research, inconsistent, poor, or you just no correlation there. So that doesn't necessarily mean that posture never matters. Once again, it's going to be dependent on the individual. It's going to be dependent on their presentation. And we can have these discussions with patients without the fear mongering or the lack of nuance that often comes along with them. So does posture matter? Sometimes it does. So let's say that somebody consistently has low back pain with prolonged periods of sitting, especially prolonged periods of sitting in a slouched position. They have low back pain when they're deadlifting. They have low back pain when they're bending down to tie their shoe. They have low back pain when you ask them to reach for their toes. So consistently, they have low back pain with lumbar flexion. Now, am I going to describe that as a postural problem? Probably not. I'm going to describe that as a temporary aggravation by sustained, repetitive, or just, one-off lumbar flexion activities. And so if somebody is constantly sitting in that position that's problematic for them, sure, you could ask them to sit in a more upright position. You could have them put a towel under their pelvis to help them sit with a flatter back. You could have them stand up. You could have them take walking breaks. You could have them do these things to get out of that posture or position that's problematic, but that doesn't necessarily mean that that's problematic for life or that they have to avoid it for life. And I think that's where the issue comes in, is that individuals are led to believe that this is painful right now, or this contributed to the pain that I'm experiencing right now. Therefore, it's off the table forever. When in reality, it's usually more of a temporary modification. And I think we'll probably get into this with some of the other sections. But even if someone says, well, I want to, fix my anterior pelvic tilt because I think my anterior pelvic tilt is causing my low back pain. Once again, it's having that conversation with them, trying to get an understanding of why they think that's the case, what they think the solution is, which is maybe, hip flexor stretching and glute strengthening, and then trying to have a conversation with them saying, hey, those are actually really great exercises, and those exercises might help your low back pain, whether or not your anterior pelvic tilt changes from a visual perspective of you looking at yourself from the side in the mirror. And also asking, would you be okay with that? Would you be okay if, your anterior pelvic tilt, your posture didn't look any different when looking at yourself in the mirror? If that but your symptoms and your function improve significantly, a lot of people are probably going to be fine with that. And I think we're also our biggest critics. So, people think that their forward head or their anterior pelvic tilt or that, you know, mole on their forehead or whatever it is, the zit on their cheek is significantly worse than what it is. And, nobody, like, if they're like, oh, I just want to do it for my aesthetic, it's probably less, noticeable than most people think it is. But that's a different thing. That's unrelated, I guess, to symptoms and function, and more so people asking questions about, well, I just want to do this because I want to improve my appearance or whatever it is.
Let's combine the next two because I think they're going to be pretty similar. The conversation around core strength or quote unquote core weakness impacting or influencing someone's risk for low back pain, or that being a treatment strategy. And then maybe more generally, muscle strength, other muscles that are commonly blamed or pinpointed, glute strength, whatever, depending on who you're talking to or listening to. Maybe those two camps, what does the evidence suggest? And are there times where it'd be beneficial to exercise those tissues, but maybe not have the narrative of it's a weak tissue?
Yeah. And so for these sections as well, looking at the totality of research, we're not going to find research saying, yeah, your low back pain is caused by a weak core. Now, it's not to say that muscle strength, muscle endurance, not to say that any of those things don't matter. So for me, I'm still a firm believer in the bio of the biopsychosocial. I think that the psychological component of the biopsychosocial model has been misinterpreted, misapplied, misunderstood in many contexts to mean that pain is all in the brain, or your beliefs are the reason or cause for your pain, or your beliefs alone are the strongest contributing factors to your pain. What I think more so, and this is simplified, that's why I had my disclaimer at the beginning, right, is that your beliefs matter because your beliefs influence your behaviors, and your behaviors are going to influence your symptoms and your function. So what I mean by that is, if you believe that your weak core, which may or not be even weak, and we don't have this cutoff of what's weak and what's not, right? But if you have this belief that your weak core is causing your low back pain, then you might walk around with a rigid trunk all day long, every day. You're walking, you're bracing your trunk. You're brushing your teeth, you're bracing your trunk. You're sitting down to go to the restroom, you're bracing your trunk. And that's just not the way that our body is meant to function. And oftentimes that hypervigilance, that constant bracing, can lead to stiffness and discomfort. Because the belief is that you're trying to protect your low back. And, the same thing with specific muscles. Now, once again, some of these things are okay temporarily, right? You go to pick something up off the ground, your back hurts. You brace your trunk, you go to pick up something off the ground, your back feels better. That's amazing. That is a way that you can modify that activity so you can do it with less pain or no pain. That modification doesn't have to be a lifelong modification. That modification also doesn't necessarily mean that your low back or that your low back is caused by a weak core. I'm also okay with, if someone has knee pain, let's patellar tendinopathy, patellofemoral pain, we say, hey, let's load the quads up. Let's try to improve your tolerance to knee extension by loading the quads up so that you can walk downstairs with less discomfort, so you can do squats, whatever. I'm okay with trying to tell people that too, is, hey, I'm noticing that when you do these activities, it seems problematic for these reasons. Here are some different modifications we can make, and on top of that, we can try to improve your low back's tolerance to that activity, to that position, right? So you can say, hey, we're going to do some back extensions. We're going to do some Roman chair extensions. Like, once again, I'm not opposed to doing those movements or exercises. And I actually think that they can be beneficial for a lot of people, because when you do have low back pain and you do have these beliefs, you also become less active, you become more rigid, and you are going to have atrophy and disuse of some of these regions. So it's okay to load that. It's just these sweeping generalizations that you have low back pain, you have a weak core, therefore you have to do bird dogs planks and side planks, or sit up isometrics in order to get better, when we don't have the research to say that that's the case. um, and once again, applied more broadly, right? If someone put 700 pounds in my hands and said I had to stand upright with that weight in my hands, like my life depended on it, I probably couldn't do it. And that weight's going to come forward, and I might experience, low back pain or something worse because of that. So that's another example of where you didn't necessarily have that didn't necessarily happen because my core is weak. I just wasn't accustomed to that weight, to that activity, and I could build up my, capacity or tolerance to be able to do that. Did that ramble make sense?
Yeah, that was solid. The specifics or more detailed conversation of core stability, we have a debunking episode on that specific topic. We have one on posture. We have one on imaging. Like Mark already alluded to, we have other conversations with other clinicians on more specific diagnoses. Last week, we had Race and Joey on for managing a spondy, Jim Eubanks stenosis, spinal or these radiculopathies with Tom Jessen. So if people want more information on those, they can go there. But the next kind of second half of this discussion is, with a lot of these different diagnoses, the principles are still the same. And Mark's already touched on a variety of them, but there are some key things with different types or experiences of low back pain that this conversation can help a lot of these different cases. In the video and in the article, Mark, you had, I think, 5 different strategies or things individuals can consider when they are experiencing low back pain. I'll list the 5 and then we can kind of go through them. And you've already touched on some of them and use some examples. 1 is modifying aggravating activities. 2 is load management. 3 is graded exposure. 4 is low back exercises, and 5 is lifestyle. So you've already touched on a few of these, but maybe we use some other examples or we focus on other areas. So let's start at number 1, Mark, modifying aggravating activities.
Yeah, and I want to say too is that when I say, hey, core weakness doesn't cause low back pain, poor posture doesn't cause low back pain, I think that frustrates some individuals. And I know you have, posts on your Instagram where you say like these things aren't the fix. And I know, people like Adam Meekins will have things that, hey, these things don't do what you think it does. And people go, well, then what do we do? If nothing matters, what do we do? And this is not to say that nothing matters. It's to say that there isn't always a quick fix, and there isn't always a simple answer that we can give to people, but there's still a lot that we can do and a lot of ways that we can help people without trying to give black and white answers. And for me, maybe other people can do it. I don't always have the confidence to say this is going to be the thing that fixes you, but hey, these are the things that we can explore to see if they're going to help you. So modifying aggravating activities, that's exactly what it sounds like. Something's aggravating, you can modify it. Right now, I'm sitting in my chair. We're doing a podcast. We're 35 minutes in. But if I were experiencing low back pain after 30 minutes of sitting, I have a standing desk. I can hit a button on my standing desk. It'll go up. I could stand up. And that's an easy way to modify that aggravating activity rather than sitting and continuing to experience that low back pain. I stand up. So modifying aggravating activities is as simple as it sounds. So what are the 3 that we talked about? Modifying aggravating activities, load management,
Graded exposure.
graded exposure. So like activity modifications and load management kind of go hand in hand. Like load management, you're thinking about maybe the volume, frequency, and intensity of an activity. activity modifications is part of that, but maybe you're also modifying the exercise or movement or posture. So an example of both would be, let's say your aggravating activity was a barbell back squat. For load management, right? You could do less weight. You could do less sets. You could do less repetitions. You could reduce the frequency of it. So you're modifying the load of that barbell back squat. And then an activity modification might be, or like a way to modify that on top of that could be changing the range of motion, maybe changing the exercise selection. Okay, the barbell back squat isn't comfortable for you, so let's do split squats, reverse lunges, something like that instead. This is not low back related, but I just evaluated an individual who has pain with walking, and they can't walk for more than 5 minutes without excruciating hip pain, and they need to sit down because of that. And so for that reason, they can't go on their normal longer walks, and therefore their daily step count is significantly reduced. Through our discussion, we discovered that this person could do very short walks. And in fact, they were at work one day, because they go into the office one day per week, and they did a lot of walking in the office, but only for a minute or two at a time, and discovered that by the end of the day, they had over 8,000 steps. So they couldn't, and no pain, no problems the next day. So unable to do 5 minutes or more in a single bout, but those short bouts were tolerable and allowed them to get a high step count relatively just by doing these 1 to 2 minute walks. And it's realistic for them to include in their daily life. So that's something that we discussed of, hey, maybe by building up just your total step count per day, per week, like over time, that's probably also going to improve your ability to walk more than 5 minutes. It's like the idea of people putting a pull-up bar in their door and they do like 1 pull-up or 2 pull-ups every time they walk to their door. Well, in the long run, that's going to help your ability probably to do more pull-ups in a row, just because you're increasing your workload there. So that was like an easy way to modify things to work for that individual. But yeah, modifying aggravating activities, load management, those are pretty straightforward. In terms of the next one, a graded exposure, I kind of listed all three: graded loading, graded activity, graded exposure. Graded exposure might be framed as like exposing someone to an activity that they're fearful of or they have a certain belief about, whereas graded loading and graded activity might be more about their tolerance to that activity. And for both, so let's say graded exposure, you think that lumbar flexion, bending forward, is extremely dangerous for your low back, for the disc in your low back. Well, a way to scale that down would be, hey, let's try a cat-cow on your hands and knees, right? It's an unloaded movement. You control the amount of lumbar flexion, and then you can prove to yourself, hey, maybe this rounding of my low back isn't so bad because I can do it without pain or with minimal pain. And then you would just scale that up over time. You're exposing that person to this lumbar flexion until maybe they get back to deadlifting or they get back to whatever activity it was. So that's kind of the belief, or maybe addressing the fear avoidant part of that. But that also ties in with the graded loading. And same thing, if we take the gymnastics example, right? Graded loading would be, okay, maybe we completely avoid the lumbar extension initially. And then maybe we do some gentle cat cows to expose you to that. And then we do some, back extension strengthening. And then we do loaded back extension strengthening. And then you start to do small back bends. And then you do full back bends. And now you're doing back somersaults. So that's graded loading. So it's really taking a structured approach to that rehab. Whatever your goal is, whatever that activity it is that you want to do, whether it's sitting, running, lifting, reaching for your toes, playing with your kids, gardening, it's just trying to find a way to scale that back and then, increase that over time.
Yeah, all of those diagnoses we discussed earlier on, these load management, graded exposure, modifying activities, it's all the same kind of principles. And like Mark mentioned, for a different context of hip pain or knee pain, any area of the body, really the goal is, all right, have I ruled out the really concerning things? And now that we feel safe about kind of moving forward, what are the things we need to temporarily minimize or modify? What are the things we can take advantage of that are tolerable? And then how do we build from there? And that will look different person to person. And someone experiencing lumbar radiculopathy versus symptomatic spinal stenosis versus just an acute localized low back pain episode, the amount that needs to be modified, the type of activities, may look different, but it's still kind of the similar thought process. The next one is low back exercises. You kind of mentioned it with that example of like this gymnast maybe has symptomatic spondy. There's an indication for kind of specific loading to the low back musculature, especially in extension. Is there anything else you want to use as an example of more specific activities of the lumbar spine or the low back, or maybe times where we don't have to be that specific with low back exercises?
Yeah, I think I gave 3 or 4 examples in the video. So one, like you said, is reintroducing activities and trying to build up your capacity or tolerance to previously problematic, exercises and activities. I give the example of the graded exposure. So you're fearful of a certain movement, trying to find a way to reintroduce that movement in a way that you feel confident. Like confidence can be helpful here too. Doing things that are tolerable and help you feel confident. Building like getting the proof that you need that you can do these things. Movement can be a way to break up aggravating activities, like I kind of mentioned. So you're sitting at your desk, you have low back pain after an hour of sitting. You could go for a walk, but maybe you want to do bird dogs. Maybe you want to do planks or side planks or hip flexor stretches or cat cows. Like all of those are great. Like those are all great ways to break up periods of, inactivity or, break up aggravating activities. Sometimes I'll do that. Like I spend a lot of time at the desk and, maybe if my neck or shoulders get a little bit irritated, I'll get up and I'll move around and like that's just a way to break up those aggravating activities. And then what's the other example that I gave? And people might refer to those as like movement snacks, like you're snacking on movements throughout the day. Oh, and then the other one would be exercises that do alleviate symptoms. And if you can find an exercise that alleviates your symptoms in the moment, that's amazing. The problem is, once again, going back to what I said earlier, is that sometimes people are led to believe that there is always an exercise, a movement, a posture, a position that you can find that's going to alleviate your symptoms. So the most common example here would be you are experiencing pain down the back of your leg, disc related. Immediately, the thought process is lie on your stomach or do, prone press ups or do repeated extension because that is going to resolve the pain. Or someone has stenosis, you need to perform flexion based exercises, you need to bend forward. And once again, the great thing about these things is that they can be pretty easy to test, right? You have this pain down the back of your leg, you're sitting at home, nothing you're doing is helping. So you go, you know what? I'm going to try these prone press ups that I saw on Instagram or on this blog or on this YouTube video. And if it alleviates your symptoms, amazing. The problem is that when it's promised as the thing that's going to fix your pain, it's promised as a quick fix, and then you do it and it makes no difference or it makes your symptoms worse, then that's an expectation violation there, right? It's violating your expectations, and that can be discouraging, demoralizing, like frustrating, because now you're unique because everyone else, 9,999 people did this one movement and it fixed their low back pain and leg pain, but for whatever reason, it didn't work for you. So now you have to look for the next quick fix. And that's the problem that I mentioned earlier, right? Is like trying to go from quick fix to quick fix. But hey, if you find a movement that alleviates your pain, uh, lean into it. Like that's why wouldn't you? I'm okay with that. Once again, knowing though that that doesn't necessarily mean that you have to do that for the rest of your life.
Yeah, to the example of someone, let's say they're an older adult, they've had off and on or persistent low back pain for years or decades, and you're the clinician trying to figure out, how do I manage this presentation for someone who's had back pain, they're saying, for 30 years, knowing that there's not one specific answer and that there's a ton of options, generally, at least for me, gives some level of like reassurance and explanation to the patient that we have a ton that we can experiment with. And if things aren't feeling amazing or are too symptomatic, that's okay. We don't have to do those. There's a ton of options. And I think there can be more general ways to go about exercise and general activity. And then the other situations, like the gymnast example or other higher level return to activities, where maybe some of those earlier things for managing the acuity of their symptoms, we still have some options. But then as the stages of rehab progress, there has to be some more specific nature of the durations, intensities, volumes, total demands of return to sport that an individual in their 60s or 70s that just wants to like manage their day-to-day walking and getting around the house and going shopping, those are just different end stage realities. But at least for a lot of these adults where they've experienced symptoms for so long, and you as a clinician may feel lost because the one type of intervention for managing back pain you were taught in school wasn't helping, knowing that something more general like walking or biking or other forms of exercise can be ways to explore integrating movement and activity that are more tolerable for this person than trying to fit them in this hyper specific stenosis based rehab plan or symptomatic spondy etc program. Let's dive into the final area that you touched on, and this is a big one, but lifestyle factors. What does that mean, and how can we think about that for managing back pain?
Yeah, and even with those more specific things, right? It's thinking about you're trying to identify the contributing factors and then modifying the modifiable. Because not everything is going to be modifiable. Not everything is like the patient is going to want to do or they're capable of doing. And so that's what you're sticking with. And maybe you're reaching for the lowest hanging fruit, or maybe the lowest hanging fruit is the thing that is the biggest contributing factor to their symptoms, but perhaps that's not the first thing that you work on because it's not modifiable for them in the moment. So the lifestyle factors ties into what you just said, right? Like now let's talk about somebody who has, it doesn't have to be this, like this could also be the acute low back pain, but if somebody does have 20, 30 years of history of low back pain, trying to find the answer probably isn't going to, like, there's probably not going to be a single answer that exists. Lifestyle factors do contribute to, the experience of symptoms, the, let's say the lingering of symptoms. And so this is just things like general physical activity, sleep, stress, smoking status, drinking, nutrition. And as physical therapists, a lot is expected of us. And for those listening, I'm not expecting you to solve someone's entire life within a single consult or even over the duration of care. These are just things that you might bring up. These are conversations that you might have. And these are things that might not change from the patient's perspective during the time that you work with them. But if you're working with somebody who says, hey, I have low back pain, I get 500 steps a day, and I sit 15 hours per day, like this is where those lifestyle factors come in. You go, okay, well, is there anything that we can do there? Is there anything that we can change that we could increase that step count a little bit and reduce that sitting time a little bit? What if I told you that exercising can actually improve your productivity? So rather than having to work 15 hours a day sitting at your desk, by getting an extra 30 minutes of walking, that might improve your productivity for the rest of the day so you don't have to be sitting as much. Right? So, and with this too, the lifestyle factors, we're trying to modify the modifiable. If somebody has a newborn baby at home and they're sleeping 4 hours per day, I'm not going to tell them, to throw the baby out the window and sleep the extra 4 hours so they get their 8 hours of sleep. Like, hey, the sleep, I understand it's going to be interrupted, uh, for the next few months. Is there anything else that we can work on? Um, and I will say that it's easy for me to say these things because I'm doing this over a podcast. It's easy for me to say because I presented in a YouTube video, and I have a larger audience that I'm capturing with that, and that's going to resonate with some people because you are choosing to listen to this podcast and you are choosing to watch the YouTube video, and you might make that effort because you are, further along those stages of behavior change and you're ready to make those changes, and that might help your low back pain. For physical therapists, clinicians working with individuals in the clinic, they might not be at that stage. They might not be ready for that. They might be looking for you to fix their pain quickly, but this is just a consideration and one that I find very important in the grand scheme of things.
Yeah, the older adult or individual that's experienced persistent low back pain, having the honest and real conversation about there's likely a variety of things that are influencing your symptoms and maybe why they fluctuate and are more intense at certain times and less intense than others. And touching on some of these modifiable and non-modifiable things, like even though they can't change some of these factors, let's say it's work-related stress or a young infant that they're taking care of and they're losing sleep, you may just acknowledge to them, these are things that you currently can't change, but it's things that we should appreciate that may be influencing your symptoms. And at least having an awareness of this point in your life, this may be something that is elevating your symptoms or maybe a strong contributor, and we can adjust it. Let's appreciate that that's an influence, but these are all the other things we can consider. The quality of your sleep, the general nature of your nutrition or dietary habits, your exercise habits, and you kind of lay out a variety of options. And you can say, like, as a physical therapist or as a rehab provider, these are the things that I think we can maybe work on together or I can help you with. But I want you to know that a lot of these other things that we discussed are just as, if not more important. And you could even bring up like these, psychosocial factors of the influence of anxiety and depression and working with a psychologist or other things that they may not have thought of that may be influencing their symptoms, but that may play a really big role. And you being, having the humility as a rehab provider to say, these are the physical things that we can talk about and work on modifying, and all the things that Marc and I talked about earlier with graded exposure and loaded movement and managing things, but also being honest and open about these other really important lifestyle or big biopsychosocial things that influence someone's symptoms, and allowing the individual to pick what feels approachable for them to adjust or to modify or talk about. And that, I think, has been really helpful. And maybe it seems like too daunting for physical therapists, but I think it, at least for me, it gives some alleviation of pressure to like list out a variety of things and say, these are the things that we can work together, but there's also a ton of other providers or individuals that may be really helpful for you in this period of your life. What are your thoughts? And kind of pushing it back to them to reflect.
And I want to say that these things don't exist in a vacuum, right? So when I say, hey, think about your stress and are there things that you can modify, I'm not saying that the stress is causing pain. It's, once again, those behaviors or what you're experiencing might influence your behavior. So you're stressed, therefore you're sleeping less, therefore you're reaching for unhealthier foods, therefore you're choosing to spend an extra hour or two watching Netflix rather than exercise, right? It's like it's this whole context and not just this vacuum. I gave it the example in there too of someone who hurts their back deadlifting, but maybe this is a college student who's studying for college finals, they're not sleeping much, they're stressed. Are those things alone the reason why maybe they eventually hurt their back while deadlifting? Well, no, maybe that stress, maybe that lack of sleep, maybe those things lead to a higher perception of effort. Maybe it leads to a reduced concentration. Maybe it reduced to, less muscle force output. Like those things can contribute, but it's this major context of, hey, it wasn't just because you deadlifted that you hurt your back, right? You don't have, this is not to say you have a weak core because you hurt your back deadlifting. Like, let's consider all of these factors and determine which ones we can work on. And maybe the stage of life of a newborn baby or finals week and you're stressed out, like that's just the stage of life that you're in. Okay, what are the other things that we can work on?
I think the last topic that we can touch on, and you mentioned this in the video and the article, the question of can you or can someone prevent low back pain or future episodes of low back pain?
How often do you get sick, Chris? Whatever you classify as sick.
Knock on wood. Depends, but typically once or twice a year.
Okay. So do you think there's anything that you could do to completely prevent that? Like,
No.
so this is the example that I gave, right? I also don't get sick very often, and we're both fortunate for that. For sure there's a genetic component in other examples, but also we live pretty healthy lifestyles. We exercise, we eat well, we try to sleep well, um, all of those things. And doing all of those things is going to reduce my chance of getting sick. But once again, life doesn't exist in a vacuum. I, hang out with my young nephews and nieces who might increase my risk of getting sick. I travel on airplanes where there's other people that are sick. Like there are things in my life that might increase my chances of getting sick, but overall, I'm doing all of these things to try to reduce that. So, can you prevent low back pain? Once again, no. And I like the analogy of being sick because, hey, the best way to prevent low back pain or try to prevent low back pain is just doing all of the things that we've already been describing, like trying to live as healthy of a lifestyle as you can, trying to be mindful of when things are problematic. Like if you find yourself, sitting for 12 hours straight every day and your low back gets irritated, like, hey, that's a thing that you can, modify to potentially reduce that becoming a bigger issue. But there are going to be times when you experience low back pain or shoulder pain or knee pain or ankle pain or whatever it is. And maybe there wasn't really much you could have done about it. Maybe that was a stage of life with that newborn baby or the finals week and the stress. So yeah, I think taking all of this into consideration that we've discussed, trying to be active, healthy, doing things in moderation, that's probably your best bet. But you can't, as people like to say, bulletproof. Like you can't bulletproof yourself 100%.
Yeah, the resource guide that Mark was alluding to, the first one that's going to come out the first week of August. This episode will come out in a few days. So in 1 or 2 weeks from now, there's this section in this low back resource guide on recurrence rates and just being generally aware of the likelihood of recurrence for any condition, but let's say something like acute low back pain. The recurrence rates are pretty high throughout someone's life. And the highest predictor or highest risk factor of having low back pain are previous episodes. So discussing that with patients or having patients be aware of that, and then giving the caveat of that's okay, that's normal. And if that or when that does occur or those episodes do come on, these are all the things that we've already discussed that you should or could think about during this next flare up, knowing that this will improve with time. This will come back down. These are all the things we've discussed during this episode of your symptoms. Have very similar thoughts for the next one, and kind of preparing someone mentally and not being dishonest and saying, this is never going to happen again. Be realistic of the recurrence that is relatively high throughout someone's life and what they can consider when that recurrence occurs. I think helps set realistic expectations and helps limit the fear or anxiety that may come on during the second course or the third course of low back symptoms. Marc, we touched on a lot. Is there anything that you want to like have a final bow tie, end things out summary wise that you want people to end with?
You tell me, Chris, what do you got? What's your summary of the past hour?
Yeah, what I would say is there was a lot of different kind of diagnoses or things we mentioned early on, but I think the big takeaway for me, or hopefully for the listeners, is that when you've ruled out the really concerning red flag things, a lot of these diagnoses, they may present differently, but really what we're looking at is where is someone starting with? What are their limitations? What are the provoking positions or activities? And how can we modify those? And how can we build them back up to where they want to be? And there's a lot of general principles for low back pain that can be translated to other areas or other type of injuries. And we don't have to be hyper specific a lot of times, but there are contexts where, depending on what people need to get back to, we do need to have a little bit more of a kind of buffer or lanes of what is tolerable and not. And for people that do want the further deep dive into specific topics or how to come to a diagnosis of something like radicular pain or radiculopathy or lumbar stenosis, we have so many different previous episodes to listen to on those topics. But the goal here was to, one, get people to watch the YouTube video and to listen to this podcast and have an idea of, even though there's specific diagnoses, a lot of the treatment options and general principles are very similar. Anything you want to add there, Marc?
Sounds great.
Okay, cool. We'll call it there. Thanks again, Marc.